Okay, it's the third and final lesson of the radiation health nuclear medicine topic, area of study, second area of study. So in this last one we're looking at radiation diagnosis and treatment. So this is very, very much just a scratch of the surface and just an overview of all of these different type of diagnosis stuff. People do degrees learning all about this, so it's really, as I said, just scratching the surface, just an overview. So first of all, X-rays. We know that we can do X-rays for diagnosis, for broken bones. All right, we know that. That's what we're usually used to having done. But we can also use X-rays to treat tumours. Alright, so treat's the missing word in there. So to do this, and excuse me, in this kind of diagram that's in your notes that I'm going to put up. Alright, so here's where we can use X-rays, to treat tumours. So here we've got this kind of thing here where this person is held down by, a mask, so they can't move their head, and you can see where the cross here is there. They'd be directing the X-rays onto the tumour that's there. Alright, we did a lot more on X-rays previously, so that's all we're going to do with those. So the next bit of scanning diagnosis that we're going to look at what we call CT scans. So CT scans stands for computer tomography. Alright, computer, because that's the processing. Alright, so the computer puts all of the bit tomography, it comes from the Greek, and the Greek term meaning slice or knife. So we're using the computer to get slices through the body. Alright, so CT scans or computer tomography, they actually use X-rays to get information. Okay, so the X-rays give them information, and then the computers process it. And the main thing, and this is, they don't just take X-rays from one direction, they take X-rays from all different directions. So the X-ray machine is rotated around the patient. Alright, and that's the other, rotated is the other missing word there. Alright, so it's a machine that looks something like this. Alright, so there we go. So in here, inside that ring there, that's the the X-ray machiney bit that rotates around, and then the person lies on this bed here, and then that bed slides in and out of the hole in the donut, and so we take X-rays from all sorts of directions, and then that gets all put together. And so when it all gets put together, you end up with something like this. Alright, so this is what you end up with. So here's would be what would be our standard X-ray of this leg by the looks of it. And all these horizontal lines that are on there, all these horizontal lines across here, they indicate where the slices are taken. And so when those slices are taken, what you can get is a cut through or a slice, if you like. That's the tomography part, the slice. Now, as you can see on this leg here, this is where our normal leg bone should be, but you can see on this particular one, it's got some stuff growing off there. So you can see that there's a tumour there of some sort that's in there. Alright, so because I use X-rays, you get a higher dose, but then again, you get information that you could not possibly have got without some sort of exploratory surgery, which they used to do a lot in the old days. Surgery to explore to see what the problem is. Alright, so we have to do that less these days. Alright, so they're slices. So the principles behind the CT scan are the same as for X-rays. So they're the principles, same principles as X-rays. So using X-rays to do it. So same as the missing word there. And then, so lots of different angles, and the computer then processes that information, and depending on, you know, the absorption of the X-rays at the different angles, it then puts together that nice picture that we've got here. So, you know, we can see a real thin around the outside here. You can see the thin bit of the skin, and then there's a bit more the fatty a bit, and then a different shade there would be the muscle, and then white here, which is bone, which absorbs the X-rays the most. So, computer, very important, using the computer and its software. All right, and so here's that was the leg, and so here's another diagram, which is in your notes. All right, so this one's across the abdomen. I haven't got my formatting quite right there. Got these words on this side, which shouldn't be there anyway. Not to worry. But as you can see, the different organs in there, because they absorb the X-rays differently. And here you can see down there a bit of the spine, some ribs here. Alright, which absorb a bit more. Alright, but the different organs, you can see different shades of grey. And as this arrow's pointing to in the text says, here on the kidney, there's a spot right there. So you can see that there's some issue there with the kidney. So with just straight X-rays, if we were to try and, you know, X-ray down through this here, then, you know, you've got the spine and things like that, and you might not be going to get that good an image. So what this allows us to do is allows us to see in behind the bone. So we can see behind bone. Alright, using our CT scan. Alright, and behind us that last missing word. Alright, so and here's another CT scan, another one here of the brain. Alright, so there it is in the brain, and then so again you can see lots of different angles. So you can see the, you know, the skull. You can kind of see a little bit of the structure of the brain depending on the tissues. Remember, the tissues absorb differently, and then you can see, of course, this spot that's there. Alright, so as I already said, more detailed images, but because they're X-rays you get a higher dose, much higher dose when you receive a CT scan than an X-ray, because you're taking many more X-rays just than the one or two. Alright, so that's it for the CT scan. Uses X-rays from different directions, and then the computer determines where it's come from, what the intensity, etc. is, and comes up with a picture. Alright, so the next one is MRI, or magnetic resonance imaging. So it's become, last 10 years or so, So basically what we do is we stick you through a magnetic field. Alright, so we use a strong one, not just strong. So there's certain people that can't have MRIs, okay, because if it's a magnetic field and you got some metal in you for some reason, then that could interact. So what happens is that you stick in a magnetic field, and then the protons in your tissues interact with those strong magnetic fields. All right, and so it's that interaction between the magnetic field, getting those protons to be jiggling around and stuff like that. And there's lots of protons in soft tissue, so that makes the MRI particularly good for soft tissue imaging. Alright, so before the image which I'm about to show you, soft tissue's the missing bit there. Alright, so here's an MRI of a head, and so you can see the cross section of the head there, so you can see the brain there, you can see the brain stem going down, you can see up here the top part of the vertebrae, and you can see in there where the discs are. We can see a whole bunch we can see some sinus area up here. Alright, so there's quite a few things that we can pick up from that MRI, and of course because each tissue's molecular structure is different numbers of protons and things like that. Alright, so, and it's very complex and it's expensive, but the big advantage over X-rays and CT is that there's no radiation hazard. Alright, so let's have a look at another image. Alright, so here's an image of, again, an MRI cross-section of the heart and lungs, and so, you can see the lungs here. Quite obvious, and you can see some other, other structures in the body, heart in that area there. Alright, again, it's all just grey stuff, and of course, as with CT scan, we need a computer to take all the info and then process it. Alright, so here's just a schematic of what happens. So there's you've got some magnets here, radio frequency to get the protons jiggling around, and yep. So all information goes into the computer. The computer then, processes to get the image that's up there. Alright. And so there's, alright, particularly good for soft tissue and neurological stuff. So here's an image. Alright, so this one here is of the spine, and on the left there before you can see that bulging disc right there pushing on the spinal cord, and then after treatment you can see that it's no longer pushing on the spinal cord. So, and originally it was developed for that. It's terrible. Originally it was developed for neurological examinations, where we can, the image can give us issues with tumours in particular, or other abnormalities as shown by these two diagrams in the brain and spinal cord. Alright, so without naturally damaging them. Alright, so again, that's a quick overview of MRI. The next one we're going to get a very quick overview of is a thing called positron emission tomography. Alright, so it uses scans using beta plus emitting isotopes, so you put radioactive material in the bloodstream or something, one that's going to emit positrons, and then the positrons that are emitted will join up with an electron as it slows down, so they only travel about a millimetre. Before they losing energy as they do. And then when they slow down enough, they can meet a negative electron. All right, and when they do that, they join, and when they join, they do what in called physics terms is annihilate. All right, and so when they annihilate, what they do is they give off 2 gamma rays. All right, and so the thing though with these gamma rays, the two, is they're not just in random directions. They are energy that's converted into 2. They travel in the opposite direction. All right, and so if we've got these gamma rays coming out, and then in opposite directions, and then we've got a detector, we can detect them. So this diagram shows kind of the idea of what's going on in there. So inside so we put the radioactive material into the bloodstream. It's down in this particular area. So there's the nuclide, that's the one that's in there. And it gives off positron, joins with an electron from something around it, and then we've got 2 gamma rays, and because they're Alright, so here's the diagram here. So as I said, we inject a radioactive material, one that gives off a positron, and so here's the radioactive material that's inside the body there that's been injected. It gives off a positron, that joins up with an electron with something else in the area. They create 2 gamma rays and they go off in opposite directions as shown there, and then we've got this ring around there that we use to collect the information. And then of course that then goes to a computer, and the computer processes that information, and what we get is a different kind of, so here's the kind of image that we would get from a PET. So this one is of the brain. So what it's actually showing us here is the functioning. So it's jumped ahead a bit. So can we get, all right. So it shows us how the organ is functioning, and you can see from the diagrams, the one on the right there, the normal one, the red's when that brain's functioning a lot. So we've got someone who's got some impairment. You can see the middle one, not so much in the way of red going on there. And then the Alzheimer's one, which you can see a lot less red, but the big thing about the Alzheimer's one is in the middle there. In the middle, that big black area, which is indicating not much in the way of activity in there. So, the PET scan, because it shows us about functioning, because that radioactive material back here, so this radioactive material that's injected will collect in an area that's functioning in some way or not functioning in some way, as is the case that we can see here. And so you get about how the organ or whatever is functioning. Alright, so the last type of scan is this single photon emission computerized tomography called SPECT. And again, like the PET, it does functioning. Oh, that's not the right letter. So tells about the function of your internal organs, and it uses a radioactive substance, just like the PET, PET, not SPECT, PET scanner did. All right. So with SPECT again, we get the function. All right. So X-rays look at things like the structure, but SPECT scans look at the function. So it can show your blood flow, for example, and that's to your heart, and what areas in your brain are more or less active. So that's in one of the missing words. All right, and so it can be grey or they can colour it in different ways. And so here's a SPECT scan. All right, so this one shows the brain, and so that's not showing structures at all. It just it doesn't look like a brain other than a brain-shaped blob. But the one healthy one on the right, or left, I should say, you can see there's some shades. It's all nice and smooth. But then when you look at the stroke one, you can see the stroke one where those arrows are pointing. There's some quite not much in the way of activity. So the strokes actually affected those areas of the brain, and so whatever that area of the brain controls, that person's going to have difficulty doing. All right. So that's it for different kind of scans. As I said, it's just scratching the surface and just a brief overview. If you do radiography, then you would do a lot of that, and it would take you a number of years to learn about all of that stuff. All right, so the last bit is radioisotopes in medicine, and radioactivity is a diagnostic tool. So with the PET scan and the SPECT, already touched on radioactive traces being used, and so we can use radioactive traces to diagnose. All right, and so here, this one here is a kidney, using a radioactive tracer, so that you would be injected with something attached to a molecule that your kidneys like. And so you can see here with these kidneys, so you can see the left one here, you can see not much in the way of activity in terms of the radioactive tracer being in that area. So there you can see there's a problem there with that kidney, quite possibly a cancer. All right, so you may think that doing that is risky, which of course it is if you have, excess radiation, to have radiation within your body, and of course it is. So what we need to do is we need to restrict the kind of stuff we put in, and this table here shows you about just some properties which would have seen before of alpha, betas and gammas. All right, so here's things that alphas, betas and gammas in terms of the energy, in terms of the penetration, etc., and ionising ability. So that's one thing to decide, which of these do we need to use. and that depends on the application. So if it's for scanning, for example, we need a gamma ray, because we need these gamma rays to get out of the body to detect them. If we want to kill off a cancer, which we'll get to a little bit later, then we'd use one of these other two, because they'll be absorbed within that cancer. Also, the other thing we need to take into account is the half-life. Alright, because we need the stuff around long enough to get information, but we want it to be kind of gone. And be able to be removed from the body. Well, alright, so we have a body within Australia that controls these things, and it's called ANSTO, the Australian Nuclear Science and Technology Organisation, and they've come up with some requirements. So for diagnostic imaging, so this is for a tracer. So first of all, it needs to have a short half-life, so hours. Alright, so that's long enough to get information when doing a scan, but it's not going to be around for days and days and stuff like that. So it should not emit alpha, because alpha would be absorbed in the body, or beta, because again beta is quite likely to be absorbed in the body, and as I mentioned before, we need to get it out to be able to scan it, so it needs to emit gamma radiation. Alright, and then the last point's got to have the highest possible activity, but not be toxic to the patient or react with the drugs. Alright, so the most useful ones that we have, most useful ones that emit gamma radiation is, we've talked about these before, technetium 99, and iodine 123. They're both isotopes that give off gammas and are very useful for that. There's also another table. Alright, and this table shows some things that may be used for imaging. Alright, don't panic, you don't need to know all the details of that, that's just some information. Now, if you're going to do that, then you need to be able to detect it. So we detect these in a thing called a gamma camera. Alright, and a gamma camera will look something like this. So again, very ring-like, like some of those other ones. But you've got a couple of big detectors there that are going to be able to detect the gammas that are coming off. So particularly with the PEC, that we have gammas going at opposite directions, so we've got those that can detect. And then of course, with all our others, we need the good old computer to be able to convert and decode all that information. Alright, so there's some imaging, but we can also use radioisotopes for treatment. Alright, so when we use it for treatment, we do it with cancer or tumours, and all cancer is abnormal cells. Alright, and abnormal is the missing word, so it's really it's a generic term. So basically it means abnormal cells. So if you've got blood cancer, it's abnormal blood cells. If you've got brain cancer, it's abnormal brain cancer cells, etc. And some cancer tumours are called benign, and all that means is that they don't move. All right. So if it's a benign cancer, they don't move; they grow where they are, and interfere with whatever it is they're interfering with at that local site, and don't move around. All right. So radiation exposure. Too much of it, it can cause cancer. But also, it can kill cancer. Okay, so it can cause cancer because it'll affect the DNA, and then the cells will start doing crazy things, and then kill it because it can kill the cells that are doing the wrong thing and doing crazy things. It can kill them off. And because often cancerous cells are rapid growth, that makes it, the rapid growth makes them more susceptible to being killed off by radiation. So that's why we have a thing called radiation therapy. All right, so what we need is just, we need optimal dose of radiation, and so we need to also minimise exposure. All right, so we need enough that we're going to kill the cancer off, but not that much that it's going to cause other problems. All right. Okay, so how do we do that? So as much as possible, we place the radiation in the affected area. All right, so we place it in the affected area or the affected organ. Now, we don't want it getting out, so if we don't want it getting out, it needs to be sources of alpha and beta. So the affected area will absorb them. And the energy, it needs to be just energy, just enough to be in the diseased section only. All right, we don't want it spreading out. All right, so here's a diagram of the kind of thing we talk. All right, so here's someone who's got prostate cancer. It says there it's an X-ray of prostate cancer, and you can see all those little reddy-looking lines there. So they're what we call wire seeds. So it's got little bits of stuff with iodine 125. Doesn't penetrate very far, so there's lots of them around there throughout that prostate cancer to then kill off the tumour that's there in that cancer. Now, sometimes we use another thing, and where we need to penetrate areas where, unlike, the prostate, we can operate and stick those in there, but there's other things that perhaps we can't. And so sometimes we might need to do the radiation externally. And this is where there's radiation therapy. And so for externally then, it's got to be gamma emitter. So if we put it internally, it's alpha or beta. Externally, it's got to be a gamma. And then we can use a thing called a gamma knife. And what we've got to do is we've got to focus those gammas on the area. All right, so we get a bit of a beam and we focus it on the area. And what we need is we need very high accuracy. Alright, just we're going to stick a high dose in a very small area. Alright, so what we need is we want the tumour to get a strong dose, but everything else we want a weak dose. Alright, so how do we do that? Well, we do that with a thing called a gamma knife, and I'll show you in some diagrams, and this will make more sense, and I'll talk about that. And so we have different beams from different, and so the beams will meet in the tumour. Right, things like brain cancer is often used. So here's a couple of diagrams. First of all, what it looks like, again, surprise, surprise, you've got that donut at the end with the bed that the patient lies on. And so the gamma rays come out of the donut. And what we have is this kind of idea. So there's your target as it's shown there, and the gamma rays from different angles. And you can see the person's head's held very, very still. Needs to be held very still in something. Can't rely on the person just holding their head still, because they won't be able to do that. They'll move around. Even if they try not to, they will. So it needs to be held very still, because we only want to get this very small target. And so different angles, so they're all converge at that target, so that target gets a high dose. But because it's all these different angles, these, as it travels into that target through those areas there, they're getting a lot less. So the good healthy brain up here gets less, the good healthy brain here, but the target gets a lot. And so that's kind of the idea about the radiation therapy and the gamma knife, as it's sometimes called. Alright, again, very brief overview. It's massive, massive area. It's just scratching the surface and giving you a bit of an idea of the sorts of things that are out there to help, one, diagnose, and two, treat illnesses, in particular cancers. Alright, that's problem set number 3. So there's some good videos on this stuff. Make sure you have a look at them, and make sure you ask if you things you're not understanding.